Hopefully it'll be.
Just like last week, every day I'm trying new position with the mic lately, so if anyone cannot hear, or if the sound cuts in and out or something, let me know and we'll try to rearrange things. Sorry for all the confusion due to the snow. I know every class you're in is being shuffled left and right. It seems like you had a 3-day week, and then a 4-day week, and then a 3-day week, and now a 4-day week, hoping that we come in the next 2 days. So sorry for all the shuffling in our schedule. I did post an announcement last night, and I think I sent emails of it, as well as updated all throughout Blackboard and posted an updated syllabus to let you guys know about all the schedule changes we are having. So starting with today, we're just doing the laboratory diagnostics in a lecture first, followed by motivational interviewing. Next week, Monday, will be a hopefully repeat of what we planned to do this past Monday, where we'll look at vital signs and physical exam assessments. So kind of just moving that over. And Dr. Sturp's lecture will be on that Wednesday, a week from today, with SOAP note development and building. The Monday following that will be your exam one. So we pushed back your exam and everything just because we wanted to get the content delivered before we give you the exam. We also shortened things up a little bit in that before you were going to have a mandatory blood pressure practice after exam one. We've had to cut that out just again due to this weather. And we're going to replace that with one of Dr. Kuhn's lectures. So you'll start with him right off the bat getting ready for that exam too. So I'm sorry to give you a lecture right after an exam. We were trying not to do that so much because we know you guys get brain fried after those, but due to the timing and due to the weather, we're having to do that. Knock on wood, we'll keep coming to school every day for the next little while, but if we don't, we will adjust things accordingly then. Let's say talk about laboratory tests and diagnostic tests that we might use and see. A lot of these you may have seen or heard with PHP206 last year. So keep what you know, but the goal is now to take it up a level. So start saying and asking you guys, well, what causes a lab abnormality or a diagnostic abnormality? Could it be drug related or disease related? Why and when do we use laboratory testing or diagnostics? Not that you may be the one ordering it, because you likely won't be if you're in a community setting. But if you're in other practice settings, you might at times be the one to order a patient's lab. So it's important that you know what is in those labs. And even if you are the community pharmacist, it's important that you know what's in the lab, because if a patient comes in and says, my doctor did lab work, if you can look and see what labs were done, you can help interpret them or translate them or find out if the right labs are being done to monitor that patient's drug therapy. So those are just some of the reasons why it's important to kind of step it up from just knowing what the tests mean and what they are to why do we do them and what do the results mean. And we're going to talk about that today in kind of a very broad basis. As you guys go through different other lectures that are systems-based, such as cardiology, hepatobiliary, with Dr. Kuhn, and so on, you'll learn more specifics of what tests are done related to those systems and what they mean. This is kind of looking at a broader sense of things. So right here, you guys may have seen this before if you've ever been to the doctor's office. They've ordered some labs for you. You've gone to the phlebotomist, which is the person who draws your blood. And you've probably seen all these tubes. And they look very colorful. It's like a rainbow, right? Does anybody know what the different colors are? Or why do we even have different colors? So the different colors code to different tube media and setups. I bring this up because one of the tube media they use is heparin. What does heparin do?
Blood thinner.
Heard a little bit.
Blood thinner.
It's a blood thinner and it's an anticoagulant. It prevents the blood from clotting. And so for certain tests, they'll use that as the base in the tube. And different color coding in different labs or different hospitals may use different color coding, but that correlates to what test needs to be drawn. So if they don't put the appropriate sample in the appropriate specimen collection, whether it be a tube or a dish or what have you, the lab can't get good results. And suddenly we have invalid, possibly invalid or inaccurate results. Coming over from there, we have a different type of blood testing. Does anybody know what we're testing over here? Or you want to set the guess?
Lead.
Possibly blood glucose. That might be a blood glucose meter. And this type of testing, as opposed to the test tube testing, is called point of care testing. This is definitely something to know as pharmacists, because pharmacists are getting much more in point of care testing. You're seeing this in community pharmacies, you're seeing this in ambulatory care practices, sometimes in long-term care facilities. This is a great way for us to get results faster than some of our previous lab methods. I can check patients' blood sugar during their diabetes management visit with a office-based glucometer, point of care testing, and I can find it out in 10 seconds as opposed to sending them to the lab where the result might take hours to get back. Point of care testing is used for a variety of things. Maybe think of any point of care testing you've done or had done to you, maybe besides blood sugar. Especially if anybody did a good deed yesterday and went next door to Finley. Anything over there? The blood drive? Maybe. Yeah. So what do they check before they take your blood? Your iron, and they check kind of what your hemoglobin level is depending on how they do it. And they might do a drop test, but they also now have a machine where they can take a sample of your blood and run it through a machine that will give them that number before they take your blood. So I don't know what the Red Cross did over there yesterday. Did you know? Did it use a machine or did you use the drop test and the little machine? So that's point of care testing. So again, it's being widely used. It's oftentimes less expensive. There are cases where certain situations where it may not be as accurate, but for most people, for many common things, it works just as well. Can anybody think of any other point of care testing devices or any other point of care testing we can do? That you've had it done before? Any other time they've taken a sample of blood, put it in a little machine, in half an hour or less, you get the results back? Maybe I maybe into a health screening, maybe related to insurance, where they checked your blood for cholesterol. There's cholesterol point of care testing now. There's even, when we look at diabetes, maybe remember last year the hemoglobin A1C test? We now have point of care testing for that. That usually takes a little longer. It's not quite as quick as the blood sugar test, which only takes a matter of seconds. But it's still coming along, and the technology is going to just keep progressing. So this is an area in which we're going to see more and more technology, allowing us to move forward with quicker results, hopefully even more cost-effective results for our patients. And since they're so easy to do, that if pharmacists can just do them quickly in a community setting, you're going to see pharmacists using these more and more, is kind of what we're thinking. And we already do in a lot of clinics. Below that, anybody know what this is? Hopefully you have this going on with you right now. We have normal sinus rhythm. Can anybody think of a condition where we might want to monitor that for a patient? Might be checking that. Okay, the heart, rhythm of the heart. So then we remember atrial fibrillation or any other arrhythmias. So we might be checking rhythms for patients that have that chronically or acutely. We might also be pulling up data if somebody's having a heart attack. We might be doing that just trying to see where the heart is rhythmically. We also may do this for some drugs. So some drugs can affect the heart rhythm or can affect heart rates. And we might do this or see this as one of the tests we do to help monitor for those therapies for their safety. So medication monitoring, safety examples. So we oftentimes monitor for things like side effects and toxicities. So can we think of a side effect we might monitor for with a lab test? I know, it's back to counseling effects, all that stuff we made you guys look up last semester, or last year or something, yeah? White blood cell count, absolutely. There are drugs that can negatively impact white blood cell counts. If we lower white blood cell count too much, we increase the risk of infection. That can be very, very serious in some cases. So absolutely. If I mentioned somebody is on lisinopril, what test might we do to check for side effects for that? What blood test could we do? Or what element are we looking for in the blood? Yeah, I know. Bring back drug stuff. But I want you guys to start thinking about how you're going to do this with drugs. I'll try to stick to the top 200, because you guys have had those a little bit. Thoughts? So does hyperkalemia ring a bell? Maybe, kind of. So elevated potassium is one of the side effects we can see with ACE inhibitors along with some of our other blood pressure drugs. And oftentimes we measure for that. We'll look at the exact panels we'll look for with that test. See if someone's having a side effect from it, if it's a safe drug for them to continue. Efficacy, targets and levels. So over here, this is a graph showing peaks and troughs in terms of drug concentration in the body of someone. Usually we look at plasma concentration of a drug. And we might be measuring this to make sure that it's getting adequate concentrations to treat a desired condition. You might see this done with antibiotics. Sometimes even pharmacists are in charge with ordering the labs, drugs, and everything with certain antibiotics in hospital settings. And they use calculations based on these values to determine if they're giving the patient the right dose. Other settings might use this to make sure that a medicine is on board at target levels, such as some of our anti-epileptic or seizure medications. We might do these things just to make sure that enough drug is on board and not too much drug is on board. We look at the two types, direct and indirect. Measuring the direct, we think of that's the actual level of the drug. So we're actually going to look at how much deduction is in your blood. With the indirect, that's more like we're looking at how much potassium, if we're getting too much potassium due to lisinopril. So we're looking for the effect of the drug, but we're looking at it indirectly. Disease state and diagnosis screenings may be another setting that we use these tests. So when we get into diabetes much later in the semester, we'll be talking about doing different tests to assess for diabetes in patients who are at risk. So some of those screening tests might be things we'll do. And again, some settings pharmacists are starting to use some of these at small levels. Maybe ruling in or out a condition. You may also be visualizing or looking at that normal condition or a normal versus abnormal, so it'll let us know about something, how it's going. So this might be, does anybody remember peak flow meters from last year in lab? What disease state do we associate those with? Asthma, absolutely. They can tell us how somebody is breathing. We usually have somebody do this as home testing day in, day out. And we can use those levels to help determine how well their asthma is controlled, how they're doing with managing, things like that. We can also tell whether the disease state is progressing, it's getting better, getting worse in response to drug therapy or other treatments. And one of the final ones, we can indicate if new therapy is maybe needed, or if we need to adjust or change that. So this drug isn't working, we need to give another drug instead, for whatever reason. So just some objectives. Note, I'm not going to go through these as much, but I'm going to let you guys know your post-class activity. We had the full activity time to do it. I was going to have you guys do more patient case-based and kind of looking and searching for different labs and diagnostics. However, in light that it's going to now be a take-home assignment and I won't be with you guys possibly when you're working on it, I'm now trying to make it a gearing of questions that will hopefully help you prep for the exam, so they'll kind of follow some of these objectives. So recognizing which components are in different lab panels. I'll have those in my slides. I'll make sure you know them. Why I want you to know them is so that if you see that ordered, you'll know what's going to happen with it. You'll know if it was going to include the right test or not. Then looking at common levels, or common lab values rather, how or when we might use them, and potential reasons they're up or down. There are a lot of drug causes, but there are some non-drug causes that you still might see in your patients that could be useful to know. Looking at examples of how labs are used to monitor medications, directly or indirectly. Looking at some important features of some diagnostic tests and things like urinalysis and culture testing. Again, this is kind of minor, and some of these you guys did see last year, so I'm not going to focus too much on these. But I still want you guys to be thinking about how they'd be used in practice now. So kind of taking a step above, I'm not going to give you as much information as we would have last year if we asked you about them. And then lastly, to identifying variables that can affect the results of lab and diagnostic tests. So things can oftentimes go wrong. If a sample is not collected right, and a variety of other things that we'll look at the end, it can mean that the results are inaccurate. If these are inaccurate results, we can't make good therapeutic decisions based on those. So that's why we need to look at some of these things that could happen in practice. Just to look back to SOAP notes, and again, due to the rearrangement of things in this class, this slide doesn't make quite as much sense, but I wanted to still leave it out there. To note that this type of information is considered objective. It goes in the objective section of the SOAP note. Again, a week from now is when you'll talk all about that with Dr. Sturp. But just kind of wanted to bring that up as a refresher from last year. Again, I know we talked about it then, but just a refresh. So common lab test panels. So these are some of the most common ones that you may see. Again, whether you're in the community setting and somebody brings you, the doctor just did these labs, what do they mean? Or maybe you're calling the provider to see if they've been ordering labs to monitor for drug therapy that a patient in your community setting is taking. Or again, you might just be looking in their chart in the hospital or other settings before you see them or to assess how they're doing. So the most basic one, BMP, basic metabolic panel. It's kind of bare bones, so to speak. It's kind of the basic panel we do. We look at electrolytes, blood urea and nitrogen, blood glucose, calcium, and serum creatinine. So kind of some of the most basic things we want to assess for. Beyond that, we look at renal panels, which are usually BMP, along with phosphate, calcium. If the calcium wasn't part of the BMP, in most cases it is, but occasionally some labs do not run that. And then total albumin. You'll notice again, as you learn about some of these other disease states, why we test for certain electrolytes, certain elements, and some of that's in the next few tables as well. So why do we look at phosphorus when we look at assessing somebody's renal function? Because when the kidneys aren't working well, it affects the phosphate levels in the blood. They can be abnormal due to kidney disease. Looking below that, hepatic. So we went from the kidney to the liver. Total albumin also included here, along with total protein, direct and indirect direct and total bilirubin, and liver enzymes. Liver enzymes that we look at most are alkaline phosphatase, alanine aminotransferase, and aspartate aminotransferase. So these are some of the major enzymes in the liver. When there's liver disease present, usually they're elevated. If we give somebody a drug that's causing hepatotoxicity or harm to the liver, they tend to be elevated. So that's one of the reasons we might be seeing these monitored for. Maybe think of a drug where we might want to monitor liver function in a patient.
Naltrexone.
I'm hearing some mumbles. We're gonna check. Think of drugs that hurt the liver, yes. Pardon? 6-MP, meaning mercaptopurine, yes. Okay, sorry. My oncology hat is not as strong as it should be. So cancer drugs she mentioned, mercaptopurine can be liver toxic, so we want to measure in that case. What else? Other drugs? Anything else that can affect the liver? All right. So other setting that we might want to test for liver function in patients is when we have drugs that are cleared by the liver. If it's affected by these enzymes, if the breakdown is through these enzymes or other enzymes in the liver, if these are elevated or abnormal, it might give us an impression that somebody's liver is not clearing other drugs as well either. Sometimes we even stop or hold drugs if liver enzymes or other liver tests are abnormal. We also look at some of these test panels, such as albumin and protein, since those are manufactured in the liver. If those aren't doing well, they might tell us, again, that the liver overall isn't processing or doing its functions to the level that it should. Bilirubin, we look at that building up in the body when liver isn't working so well. So all kinds of other concerns we might see going on with liver issues. So again, these are the tables I mentioned. And I constructed these, again, you could obviously put in a lot more detail in these tables than I gave you. If you pull up some lab references that are out there, some of the review papers available, they can give you many more causes of hypo or hyper electrolyte imbalances in the body. I just picked some of them that I think is important for you guys to know kind of as a baseline now. Don't go out of practice and say these are the only things that can cause, we'll say hyperkalemia, for example. These are just some examples. These are examples I would like you to know just for this class. You might get more throughout the semester from other faculty, but for right now, I think these are a good start point of some of the common things we see that might cause these abnormalities. But again, there are many others, just because there's so many things out there. So I want to limit it and not give you hundreds, but make it kind of just some of the things you might see in practice. So even things like sodium, we know the basis of it, that it's the most common extracellular cation. So by comparison, when we have numbers for this tends to be 135 to 145 up in that level, whereas by contrast, potassium, the other cation in the blood, is not as prevalent. It's more prevalent intracellularly, so its blood concentration, plasma concentrations are lower, usually 3.5 to 5 is the average range for normal labs. And be aware of the numbers I'm throwing out here, big disclaimer. Numbers and normal values for labs will vary with the lab where the sample was run. So some hospitals, the normal for potassium might be 3.5 to 5.0. Others, it might be 3.4 to 5.2. So always you need to look at what the lab reference ranges are before you deem something normal or abnormal, unless it is a test like an INR where there is a normalized value that you're looking for, or normalized base value. So again, keep that in mind. The references I posted for you guys are the ones that I'd have you guys use in class just as kind of a baseline reference point, because they're, again, fall within that kind of normal range that we expect for the lab. However, always make sure that whenever you practice in another setting, you find out what their normal ranges are and practice by that. So questions about these are, again, some of the very, very basic ones we see. The sodium, chloride, potassium, and CO2, or bicarbonate that's in the blood. You guys all have these going on right now. And some of these things that could cause them to be high or low, you may have even experienced things like GI distress. Look at a few more of them, and these are a little more complex. We look at calcium, magnesium, phosphate, and glucose. So glucose should be the big one that everyone thinks about. What's the big disease state where you worry about glucose being elevated? Diabetes, excellent. Working on the right check, there we get cylinders firing. So that's one of the most common things we think of. By contrast though, there are some drug therapies like corticosteroids that can also increase blood sugar, especially in patients that already have diabetes. We also look at some things that can cause your blood sugar to be low. Either a patient with diabetes may take medicine and accidentally taking the wrong dose, or a patient who maybe doesn't have diabetes, or maybe does, who's skipping meals or not eating regularly or in healthy quantities, and maybe suffer from low blood sugar at times. We put these together, or at least put some of these together in the basic metabolic panel. We usually write it out like this. It's called a fishbone diagram. So we have a fish for today. I don't know what kind it is, but maybe you do. So fishbone diagram, you'll see these often commonly used. They're seen more in paper charts. I think now that labs are so commonly displayed electronically, you're not seeing them as much. But you still may see them in practice, so it's important to know what goes where. It's a standard format. Always looks the same way. These elements always go in the same places. One way to remember it, and I'll just give you this mnemonic, but if you'd like to make up or come up with your own, feel free. This is just one of the ones that I have filing around. Is to go by columns, and always know that you're going to get the high numbers over the low numbers. So we just said sodium is more prevalent in the blood than potassium. Same thing for chloride versus carbonate, or versus CO2 rather. So the abbreviation is CARS. So first column we have cations, right, chemistry. Anions, renal values, we'll talk about the BUN and serum creatinine are values that help us with renal function estimates. And then last, sugars. So again, if that helps you remember this, good. If not, come up with something that does. You will probably see this again. You may get questions on this again. It may not be in the exam per se, but you may have labs given to you like this in patient cases, and we won't tell you what's what. You just need to know what's what, because that's how you may see them in practice. There, just a common way to see them sketched out. You'll likely see at the point of rotations or at some point in your practice. So, whoops. So that takes us over to those kidneys, which is some lovely kidneys up there. I thought I'd just put a picture of kidney beans. I wasn't sure if people would get it. So we went with actual kidneys instead. No, you're not required to know the anatomy of them or anything like that for today's class. But we need to look at some of these lab values that relate to them. So serum creatinine, oftentimes just called creatinine. Derived, it's a byproduct of muscle breakdown. It's cleared by the kidneys. That's why we look at it to measure kidney function. That being said, it's a very imperfect marker in that there are other factors going on in the body besides kidney function that can cause it to be elevated or depleted. So again, it's a very imperfect marker. Very important to keep that in mind. We use it very widely in practice, but you always kind of have to take it with a grain of salt of it's not always the best picture of everything in the body. The reason being is that we have patients who have more muscle breakdown and other patients who have less muscle breakdown based on body size, age, and other factors, and this lab value doesn't take into account those things. So again, interpret with caution and be the warning. It goes up usually with kidney failure as well as dehydration. So even if we over-diurese somebody, so what's a diuresing drug? Water pill. Sorry? Hydrochlorothiazide is a great one. Lasix is another one. Excellent. So if we give somebody too much of a diuretic, and we'll actually see this sometimes in practice, if we over-diurese them and cause dehydration, we can actually bump their serum creatinine. And if we back off the drugs, serum creatinine goes back down, hopefully. So we've seen that in practice too. We've had patients have to stop some of their diuretics because of that. So ideally, that's why with those medicines, we need to be cautious and give the right amount and not too much. By contrast, when somebody has a loss of muscle mass, which may be due to a variety of health conditions, not being able to eat well, poor nourishment, nutrition, or other negative diseases like cancer, that loss of muscle mass might bring down the serum creatinine. Now, that doesn't mean that their kidneys are doing any better or worse. It just means they have less muscle mass to be broken down to give this marker. We use it to estimate things like the creatinine clearance, the glomerular filtration rate, and those, again, are estimates of how good the kidneys are clearing things. So if we have a drug and it clears mostly through the kidneys, we want to know how well those kidneys are clearing things in general. And I imagine you guys got a little bit of that with PK last semester. You'll get more with PK next year. But again, we just think of, when we think of renal and hepatic function, we worry about drug clearance. Looking at the BUN, or the blood urea nitrogen. This one, again, has to do with protein metabolism. It is produced by liver and cleared by the kidneys. So again, we're looking for kidney clearance, and this being a marker of it. Again, affected by other factors going on in the body. Usually elevated, just like supercreatinine, we worry about elevations, meaning that kidneys are not working as well. However, when it goes down, it doesn't mean kidneys are great. It could just mean that liver is not doing well. We also usually compare these two markers in a ratio, and we want that ratio to stay within a certain low range. If it is elevated, then we consider that could be a problem or indicative of certain kidney diseases. So moving on to the liver. These are just a variety of the panel items we use when we assess liver function. Do these lab tests. Albumin, made by the liver. Does anybody know what albumin does when we think of drugs, especially when we think of pharmacokinetics of drugs? What does albumin do? Binds to them. Excellent. That's the PK revival from this semester. That's the PK concept I need you to know now. So if your liver is not making enough albumin, because your liver isn't functioning, what happens to that drug that binds to the albumin?
More available.
More bioavailable, absolutely. It's not bound up, it's free drug, it can get to receptors and other things instead. This can also come into play if you have different drugs in the body that are competing for those albumin binding sites, and if we're depleting the binding albumin sites because we have low albumin, that's a problem. So that's again one more reason that we worry about liver functioning with our drug therapies. A few other things that we look at that are less common, the alpha-A antitrypsin. Don't commonly see that one, but it can be part of some hepatic panels. Again, the alkaline phosphatase, the ALT, AST, we do see those quite a bit. GGT, not as much, or the gamma-glutamyl transferase. So again, some of these are more common than others. It may vary with your lab and what all they run with the hepatic panel. So again, these are some generalized ones that would fall under hepatic or LFTs. But the actual slides I give to you where I line up what is in a panel are the ones I want you to know for the test. Some of these are extras that you might just see in certain lab settings. Also, we look at the bilirubin like we mentioned. May also even do a urine test for bilirubin to assess how it's clearing. And then lastly, prothrombin time, so PT. So anybody recognize what prothrombin time is? Anybody seen that before or heard that one?
Clotting time.
Clotting time, absolutely. So how well the blood is clotting. Why do you think that's a marker of liver function? What's made in the liver? I know it's back to Pat though. It's all the horrible people in classes are coming back in this one. I know it's not the class. So if we're looking at different markers, and PT is one of them, we can do a few others too, that look for clotting time. It's a function, or it shows us how well liver is functioning because liver makes a lot of the clotting factors in your blood. So all those factors tend to, all the proteins, CNSs, things like that, those are manufactured in your liver. If your liver is not working well at manufacturing them, your blood won't clot as well, and we can measure that with some of our tests. That is one of the problems we actually see in patients with advanced liver disease, is that their clotting ability is decreased. Sometimes they have bleeding events as a result, which can be very serious. But I'm going to step away from that before I steal Dr. Kuhn's thunder, because he will tell you all about that in a few months, or I should say over the next few months. So again, these are the panels, or some examples of panels I would like you to know. CMP, or the complete metabolic panel, is a BMP plus a boost. It's BMP along with the albumin protein, bilirubin, and the liver enzymes. So those three enzymes that we talked about that are most commonly done. A CBC, or complete blood cell count. And this can be done with differential as well. Differential breaks down the different types of white blood cells, and we'll look at that in a minute, because they're not just all the same within that category. We look at leukocytes. Some CBCs, other things they might give us are the mean cell volume, the mean cell hemoglobin concentration. These can also be markers of, again, how strong our red blood cells are, in addition to just the hemoglobin hematocrit values. So again, if you look at a red blood cell, they all contain this great protein called hemoglobin. We know we have this. What does hemoglobin carry in our red blood cells? Oxygen. That's why it's important. That's why we care about it. And that's why in patients who have low hemoglobin, they tend to report things like shortness of breath, because they're not getting good oxygenation to the rest of their body. Even if they're breathing fine, the body just isn't transporting it well with these red blood cells. So again, These can be affected by a variety of things. However, in general, for both hemoglobin and hemocrits, we look for certain conditions that can cause them to be elevated or depleted. So elevation, things like polycythemia vera, as well as chronic hypoxia. So we might see this in patients who are chronic smokers or COPD. These can be also decreased by things like bleeding or bone marrow suppression. So we mentioned earlier one of our chemotherapy drugs, one of our anti-cancer drugs. A lot of these drugs that we use to treat cancer are associated with bone marrow suppression. They can decrease hemoglobin, hematocrit, as well as sometimes white blood cells or red blood cells, depending on what type of cancer or anti-cancer drug they are. We may also see abnormal cell morphology in red blood cells, or even in the case of pregnancy, sometimes that can cause low values for these if a woman's body is being depleted and so on. So again, just a few of the causes. There are many, many more. Perhaps there's many, many more things that could cause this, but these are a few things we watch for. Again, we look at those white blood cells. We can organize them out with neutrophils, lymphocytes, monocytes, eosinophils, and bands. It's important to know those. I think you got a breakdown of those a little more with immunology last year with Dr. Gavinch. What each one, which cell lines are, what they do with these. I'm seeing some bubbles. If not, at some point you will review that because it'll come up with an ID again. To remember these, there's, again, finding mnemonics could help you. I think the other one I heard was never let monkeys eat bananas. It's one of the ones that I think we got when I was in school. I don't know if that helps you or not. It sounds very preposterous, so maybe that's why I remember it after time. But it's one of the ones you can think of to get through those, to know what they mean. Because when you get a blood cell count with differential, and these are different abnormalities, it can tell you things like how a patient's infection is progressing. They can be increased by things like leukopenia, trauma, or infection. So again, they're responding. Your immune system's in response. They can be decreased with certain viral infections, actually, as well as aplastic anemia and bone marrow suppression. Again, we're worried about some of those anti-cancer therapies we have. Beyond that, platelets, one of our important clotting components. Again, we worry about increased risk of bleeding when these go too low. They can be increased, though, by infection, malignancy, hemorrhage, and iron-deficient anemia. They can be decreased by certain autoimmune diseases, chemotherapies, and some other medications. So these are just two medications that can decrease them. However, it's important to note that decreased platelets can be caused by a variety of medications we have out there. And we give those drugs to patients, that might be a reason to order this as a monitoring parameter. So these also come in a great diagram. Again, not as commonly seen as when we use more paper charts in practice, but still important to know in case you ever see this written out in a chart, because some places still do use paper charts or do use physician writing. White blood cells on one side, hemoglobin, hemocrit, again, this time low over high as opposed to high over low. So hemoglobin's usually about 1/3 of your hemocrit. And then far side platelets. And you could call this white hot pizzas. Again, don't ask me where some of these things came from. I don't know why I remember them, I just happened to and they helped. But if you like something better, come up with something better. If you like planets or who knows what makes more sense to you. But make sure, again, you can recognize these types of panels because you'll probably still see them in practice at some point. They're not totally obsolete yet. 5 years from now, I might not be teaching these anymore, but right now we're still seeing them sometimes. Some other tests and panels. So we look at endocrine function. We might test for thyroid disorders, thyroid disease with things like TSH and T4 testing. Diabetes, we might look at the glycosylated hemoglobin in addition to just that blood glucose that we do as part of a BMP. Lipid panel, always important, we're checking for cholesterol, one of the big cardiovascular risk factors that we watch for. Vitamins and minerals, we might look for deficiencies causing disease. So does anybody know what concerns we have with vitamin D? Because vitamin D testing is very, very big. It's becoming more and more common, and we especially see a lot of it in Maine. So why do you think we test for vitamin D? Any associations or any things you guys have heard about that? Pardon? Seasonal affective disorder is one condition that we could see with that. What? Oh. Anybody? Bone health. Bone health being huge. So again, if you don't have enough vitamin D in our bodies aren't able to process calcium as well, and that can deplete the calcium stores in our bones, increasing risk of osteopenia, osteoporosis, and in turn, unfortunately, fractures. We especially see in our seniors. Why are we so worried about it in Maine? why are so many of my patients in Maine vitamin D deficient, including myself, who's tested vitamin D
No
deficient?
sun.
Direct sunlight.
Yeah, we're missing that direct sun. I know the sun's out today, but let me tell you, when I walk outside, I have very little sun exposure. I'm not going to be sunbathing when it's 30 degrees out. Just not happening. So vitamin D levels, especially in northern climates, or especially in populations that don't get much sun exposure, becomes a much bigger thing that we're seeing. Probably if I was working in Florida, I wouldn't necessarily see it as much. That being said, we're also finding associations of low vitamin D concentration with use of certain medications. Certain antipsychotic medications, even some anti-seizure medications, some of the steroid drugs we even use to treat breathing disorders like asthma and COPD. Sometimes we're starting to see with chronic use of those lower vitamin D levels that sometimes require treatment. So we're seeing more and more indications or reasons why vitamin D might be low and why we should assess it and possibly treat it. Keep people at normal levels to help prevent adverse events. We look at anemia workups. So iron, B12, and folate. If you guys remember way back from last year, all 3 nutrients in our diets that can lead to anemia or poor red blood cell development, morphology, or function. So these are all things you might test for if somebody comes back positive for anemia. We look at the heart. We have some cardiac markers, things like troponin and brain natriuretic peptide. Again, you'll get the more details on these when you get to the cardiology section with Dr. Sturp towards the end of the semester. For now, just note that some of these, again, what body system they relate to, that's all you need to know for today. I'm just kind of breezing on them to let you know they exist. Infectious diseases. So we might do have hepatitis panels. We might also be testing for HIV or effects thereof. Might do certain immune cell testing that we wouldn't normally otherwise do if somebody has HIV or suspected of having HIV or AIDS. Hematology or coagulation markers. We oftentimes do these to monitor safety and efficacy of anticoagulants and antiplatelet agents. So I mentioned heparin is one of our anticoagulants. Another one up here is warfarin. And we do sort of testing associated with these to see that they are effective. However, with long-term use of these or antiplatelet agents, when I say antiplatelets, what might be some of those? What drugs affect our platelets? Plavix. What else? Common one all over your OTC shelves. Aspirin. So aspirin, Plavix, Pressurial, all those drugs that affect platelets, or some of our anticoagulants like this one is a long-term warfarin, or another long-term anticoagulant medicine like the new ones we have coming out, or that have been out for a while, I should say, like rivaroxaban. When people are on these chronically, we still might want to be testing a CBC every so many months, depending on your clinic and your protocol, to make sure that we're not causing an adverse bleeding event that is subclinical, which means the patient isn't complaining of bleeding, they may not be thinking they're having a bleed, and yet they're having maybe a small stomach bleed or something like that we'll only catch if we actually look at the hemoglobin levels. We might catch it until it's very low if we're waiting for symptoms to crop up. Some of our blood proteins, again, might look for those. We're looking and worrying about liver function, functional proteins in the body, and those that may be bound by drugs. Toxicity screenings, and this may be done with blood or urine, so things like alcohol, and alcohol, yes, it should include breath because we do breath alcohol tests, which we do out, or have our law enforcement doing out in the community. We also test for acetaminophen toxicity this way, cannabinoids, and opioids. So again, all these might be reasons that we're doing screenings for toxicity. Important to note, though, there's some overlap. So if we do urine drug screening between different drugs somebody's taking in, and that's not an uncommon question that we've gotten in pharmacy of, well, patients' urinalysis came back positive for this, but I'm prescribing that. Could there be an overlap or false reading because of certain drug combinations? And sometimes there can be. Sometimes it is actually the patient's is taking what they're supposed to, and again, due to other drug interactions or other conflicts, it's not showing up the way we'd expect it to on urinalysis. Speaking of urinalysis, these are dipsticks. You may have seen them in practice. You may have seen them in like a biology lab or something before, or maybe in your doctor's office. These are a very quick way to assess urine for just some markers of abnormalities, things like protein or sugar in the urine that shouldn't be there in any terms. So again, just simple urine sample in a cup, and we can dip this device in this little test strip in and compare it by color, and color changes would indicate presence of abnormalities in the urine. So again, kind of like a point of care testing where it's a very quick test. By contrast, we can also do clean catch urine or even 24-hour urine collection. Not commonly done, not very easy with patient compliance, but occasionally we do still see that asked for. Mostly we just do a clean catch urine sample, And the specimen can be assessed for things via observational assessment, so clear versus cloudy, the color, and then we can also do testing for things like pH, specific gravity. We can culture the urine to try to see if there are microbes in there that are growing. We can gram stain those microbes and try to see what species they come from. And those can all help guide our treatment. We also look for, again, some of these other presence or absences that usually, if they're there or they're in significant quantities, indicates either there's something wrong with the kidneys or there's other diseases present. So again, things like urine nitrite. Usually don't see that unless there's some type of infection going on. So microscopic features. Microscopy is one of the big areas that we do a lot of lab work, that we look to as pharmacists for help. So again, everything from gram staining to culturing, biopsying of tissue is something that we might also see. Cancer is suspected, or there's risk, or again, certain other diseases where we need to really look at the cellular level of things. Biopsy samples may be taken. Can you tell me what this dish is up top, what this is trying to do? You guys seen that maybe in a biology lab somewhere, or?
It's an MIC test.
So I'm hearing this?
It's an MIC test.
MIC test, absolutely. So it's a minimum inhibitory concentration test. So this is a petri dish, you're probably all familiar with, and somebody took a bacterium sample from a patient. They smeared it all over this dish. They got it to grow really well, so it came up with a full growth. And they dropped little discs on it to see which drug treatments, usually it's done for drug treatments, which antibiotics will actually cure or treat that microbial infection. So each of these little dots that you see, each of the little white circles, or well, I guess that one over there on top looks yellow, each of those little circles either has a different antibiotic or a different antibiotic concentration. And we plot them down, and the ones that don't stop bacterial growth, we say, that one's not effective. Don't treat with that drug. Versus the ones that you see that have large margins around them, we would use those drugs preferably if the patient will tolerate them, because those are the drugs that will actually treat that bacteria. Sometimes if there's resistance issues, if there's other concerns, if it's a worse infection, it's not responding to antibiotics, we'll do advanced testing like this to try to see what are we doing wrong with the treatment side of it. So if we're giving a drug that the bacteria is not susceptible to, it's not going to work. Unless it's at very high concentrations, but even then it might not work. So some causes, variability and errors in labs. So again, all kinds of reasons for abnormalities. Again, sometimes labs should be done in patient or lab normal ranges are sometimes specific to patient's age or gender, or age or sex, I should say. Body type and hydration status may also come into play. Medications being on board may also inhibit or might also affect certain lab values. If patients had medical procedures done recently, or as changes in their health status, it may also affect their lab values. Also just things with the sample collection. So again, we use the wrong tube. Blood sample might not be correct for the test we're doing. If we mistime it, so this is something we oftentimes see when we're doing certain drug testing. If you don't time that test of the blood for a drug concentration with either the peak or the trough, whatever we're going for, if the nurse draws the blood too early, too soon, or sorry, too early or too late, we might be getting the right numbers. We might be actually getting the true peak or trough of that drug level in the blood. And that can, again, in turn, not allow us to make very good therapeutic decisions with how we're doing our testing and our, in turn, changing of doses. So some other diagnostics, again, these are some of the visuals you might see, things like x-rays, CT scans. I know we went over them all last year, so I'm not going to go over them much. These are just some brief descriptions of them for you guys to keep in your mind as a review. Just kind of some basics about them. Maybe you guys have had some of these done, maybe you know people that have. Again, looking more disease state specific or body system specific, we have some of our cardiac tests done, things like cardiac catheterization that can assess as well as maybe treat blockages of the coronary vessels. We look at GI, we have things like endoscopy. I thought of putting a barium swallow picture on there because they're just kind of cool, but they're also kind of creepy. All the pictures I started putting on looked really creepy because they're x-rays of people swallowing things and things going down people's stomachs and things like that. So I got creeped out by them and I said, you're just going to have to do an endoscopy picture. So if you're coming barium swallows, you'll have to look for that elsewhere. But even in some cases where we expect certain acid diseases, maybe even actually do a 24-hour pH monitor, or actually put a pH monitor in somebody's esophagus area to assess for acid reflux. So pulmonary, we already talked about peak flow test. We also have spirometry associated with that. So like we monitor our patients with things like COPD and asthma. We look at look at some of the genitourinary tests, colposcopy or pap smear. We also look at things like digital rectal exam, which oftentimes used as a baseline assessment for prostate enlargement or prostate cancer in some patients. Again, all these being options or being ways we might use labs or diagnostic tests to determine somebody's health status and in turn the need for treatment. Oh, but this one down here, actually, can you tell me what this one is? It's a better picture than we had for you guys last year. Wave your finger. We're emitting light through it. O2 saturation, absolutely. And some of you guys may have had this done before, may have been at Oxford where they had this. Pretty neat. So again, some of the references associated with this section. Again, some of them are other texts. If you ever need access to these, I have some copies as well as the library has copies. And then again, some of these reference values that are posted for you. So for the lab, we are only guessing, but hopefully I will take some questions from you guys if you have any before we break. Things that aren't clear, yep.
On the slide with the genital urinary tests, are you saying that a pap smear is the same thing as a colposcopy?
No,
Okay.
but if there's something wrong with the tabs in here that I need to fix, then I can fix that because they are not the same, but let me, yes, and it looks like from the tabs that they were put in that way, so let me correct that, and please correct that on your slides as well, because they are not the same thing. Thank you very much for catching that. That was a tab error on my part. Other questions though? That's a good one. Oh, I'm sorry. Sorry, let me play back into that. I apologize. Sorry, what she was asking, what I just tabbed over was the pap smear that had been accidentally tabbed under colposcopy, but it shouldn't be tabbed under colposcopy. They should be two separate tests. Now, sometimes they are done in conjunction with each other, but they are not. Pap smear is more routine. Colposcopy is only done with selected cytology, I guess is found. Is a better word for that. Other questions though? Other sections that are unclear, you're not sure what you need to know. Again, I know it's a lot of information, but I'm hoping the practice question I'm going to give you at the end of the day will help with some of it. Pretty good? Okay, we'll come back at 2:30. We'll go through motivational interviewing.